at a small software design consultancy in Boston called Envision Studios. And we design software predominantly for healthcare, but I personally have been spending a lot of time thinking about care planning for a variety of clients ranging from Johnson & Johnson to SeniorLink to UpDocs, and I've also co-authored a three-part research and design series as well. And a common thread throughout all of those projects has been thinking about how do we engage people to behave healthier. The projects that I've worked on have ranged from patient and clinician-facing mobile apps for caregivers monitoring their loved ones, to patient health experiences, to mobile care planning apps for anything from diabetes to schizophrenia, analog care planning components, and then some patient education as well. And in translating the insights from those projects, as well as secondary research and talking to experts in the field, we really kind of honed our focus onto this idea of, well, what exactly is a care plan? And it turns out there's not too much consensus in the industry for what that definition is. But in our work, we've kind of narrowed down three components to that definition. The first is that it's a synthesis of all plans of care, so across the entire spectrum of medical encounters. It's driven by you, the patient, and your care team, and it's an ongoing, living framework that follows you around. Care plans typically contain a patient summary, however brief, health concerns or the conditions, symptoms that affect their health, the goals or desired outcomes that they want to reach, instructions and interventions or the steps to reach those goals, and then some kind of means of reviewing progress and adjusting that care plan as necessary. And that's all facilitated by a care team. But the problem is care plans don't really exist yet in today's practice, and there's a lot of reasons why that's the case. And to kind of demonstrate this, we can look at Edward here, who recently broke his leg, and he's now seeing his primary care doctor, Dr. Yang, after an emergency visit 1 week ago. Edwin had trouble getting a hold of the right people to get his health records sent over from the hospital, and Dr. Yang can't get in touch with his ER doctor and must rely on his account for important health information. There's no standard communication tool across these institutions to discuss Edwin's transition in care. Because she doesn't have the whole story, Dr. Yang has trouble working with Edwin to create the right plan. She might ask questions in a way that Edwin doesn't understand, and he might not give the most accurate answer because he's self-conscious or unsure. Edwin receives a plan from Dr. Yang, which may or may not line up with the one that his ER doctor gave him. And when he's referred to an orthopedic specialist, he'll get a potentially differing plan as well. There's not one holistic plan shared across his entire care team, and there's no standard content for his care team to pull from. Edwin is concerned about what people will be able to see in his health record as well. Since he doesn't have full control over his health information, he's hesitant to provide more than what he thinks is necessary for Dr. Yang to treat him. He tells Edwin to come back and see her again in 1 month to check his progress. But Edwin's health status could change drastically in that period of time, and he'll still be following the same potentially harmful course of treatment. After Edwin leaves the office, there's a 50% chance of him continuing his prescription if he even fills it. After rehab, he'll start an exercise program that he'll have a 1 in 2 chance of quitting before 6 months. He received very little education about how these health behaviors that are prescribed to him will affect his outcomes. And Edwin, like most people, doesn't really want to think about his health. So unless a care plan is designed in an accessible, engaging way, it's probably not going to be followed outside that doctor's office. And the current clinical standard for providing a visit summary for addressing this problem is really not too effective. And I can attest to this personally. This is a real-life visit summary from my real-life doctor's appointment with a real-life plan of care. As you can see, there's not too much there that's telling me how to behave in a healthier way. And since less than 1% of care happens in the doctor's office, the other 99% is up to you. So how do we get health interventions to stick and promote self-care? A big part of this problem is that there's a huge shortage of medical professionals. We all know this, right? In a recent study by the AMN Healthcare in 2013 of healthcare executives, 2/3 said that they needed more doctors and nurses, and over half said that they needed more nurse practitioners and PAs. But recently, Medicare started reimbursing for quality holistic care via methods like the Chronic Care Management Code in 2015, which is getting professionals to create an actual plan to deliver to the patient. But the problem is it only really applies to Medicare patients with 2 or more chronic conditions. But once the value of this model is proven, we can hopefully start shifting those incentives towards other payers and start incentivizing preventative care as well. But with things like this CCM reimbursement and the shift towards alternative payment models in general, like ACOs and CPC+, we started to see an emergence of these care management services. And as they evolve along with our sensing technology, lower power connectivity, and better data analytics, we have this amazing potential to engage and provide quality healthcare to that 68% of people with a smartphone in the US. And this concept for including the patient in a digital solution to better their health is still fairly new. We have a long way to go in determining how to effectively design solutions so that they work for the patient. But I'd like to start the much needed conversation about what the core principles are for designing care plans. And I'll go through each one of these in a little more depth. So the first one is kind of obvious, but unfortunately needs to be said. We need to actually start giving a care plan to patients. Most don't get one, and if we really want to reduce costs and improve outcomes, that really needs to change. The second one is the idea of facilitating patient-driven goals. And this means understand where they are versus where they want to be, identifying what barriers exist and how they can avoid those barriers, using techniques like motivational interviewing to identify what the steps are that they're willing to take, and then also using models like BJ Fogg's tiny habits and triggers to outline exactly how they can reach those steps. So an example for how this might work in a digital solution, this is a concept of a care plan builder that a patient might work with some kind of a care manager or clinician to fill out together. And on the left, you can see that patient's conditions along with the symptoms associated with those conditions. On the right, you can see they're invited to enter in what high-level goals might exist for them to help them that are associated with each of those conditions. And then on the second screen, we can see those goals that the patient has entered kind of contained into those conditions. On the right, in the purple text, you can see what you might traditionally think of as the doctor's orders, right? The super vague, use inhalers needed, exercise more, change your diet, that the patient doesn't know what to do with. But in this example, we're identifying where they are with those behaviors, where they have identified that they want to be. And the most important part is drawing that connection between those health behaviors and their desired outcomes on the left. And this is all kind of done manually now, but ideally we'll move towards a point where this is a lot more automatic. And to kind of help you see how this would actually work for you, I've created a little handout that everyone has on their desk, if you can turn it over, and you can fill it out on your own. Let's kind of employ some of these elements that I'm talking about for goal setting. The second design principle I'll talk about is making accuracy effortless. And this means collecting the right data at the right time with as little workload as possible. And this can be done through a variety of health trackers, right? That list is growing, there's new ones every day. But the important part is that you're monitoring relevant health metrics to that particular patient, and you're monitoring progress towards specific goals. An example of this might be a Bluetooth spirometer that the patient has in their pocket with them every day, and that they can just with a quick puff blow in, get their lung function, and not only the lung function, but insights about that data and useful tips for what to do with it. If we look a little further into the future, maybe there's something like a smart mirror where you're tracking mood through facial tracking and maybe even heart rate through skin pigment, and then displaying helpful information back onto the mirror for them to consume. And this kind of translates into the next design principle, which is this idea of giving actionable insight, because the data isn't as important as what you're actually supposed to do with it. This means giving relevant education and action steps to improve based on that data that we're collecting. And this can be as simple as a doctor giving a patient an educational pamphlet that's relevant to them, or it could be as high-tech as a mobile app that the patient has that is tracking things like their physical activity, and not just displaying that physical activity, but actionable insight about it. So you've been still for over 2.5 hours, maybe it's time to get up, take a walk. Here are some restaurants that are in a good 12-minute walk from you. And hey, while you chose to go walk to one, we can give you even more actionable insight about healthy tips of what to eat at that restaurant as you walk to it. Another fairly complicated design principle is the idea of making health history human readable. This is a very complex issue, but I'll just go over a few kind of items within it. The first is just displaying the health information chronologically over time, the way that we read it and think about it and the way that it happened, but still allowing you to filter it by important health condition or aspects like condition. And then also including some kind of patient summary, ideally facilitated by a generalized health score. And the second that you have more than one data point, you have the option to show a trend visualized over time. And then especially with more advanced data analytics, we can show future predictions as well. And then another key point here is to allow the patient to edit the record, to allow corrections to reduce that inaccuracy in data, and then even to collect more qualitative information like big life events that might affect health. So a concept for how this could work would be a mobile app like this for the health record, where they can browse by section, but they can also filter by condition. So here you can see their general health score is a 63 out of 100. This is aggregated across all health metrics that are important for that patient. And then you see the 3 conditions that they have that are keeping them from reaching that score of 100 and the trends of those over time. So that they can say, hey, I want to increase my score by 5 points. They tap into hypertension to actually dive into the specific plan of care for that condition. Another really important design principle is the idea of designing for collaboration across the entire care team. And this means doing it as synchronously and as contextually as possible in a way that's driven by the patient and their care navigator or manager or whatever that title is that might exist for the patient. If we visualize that care team across the whole spectrum, we can see the patients and their family, their core family kind of at the hub of this network. And then immediately surrounding them are the really frequently interacted with core care navigators. And this could be a low-level professional, it could be their PCP. And then immediately outside of that is the extended clinical team. So the specialists, the therapists, maybe even the gym assistants, people that are helping them with their everyday health. And then even outside of that is the social care team. So this could be extended friends and family, or it could be online patient communities as well. So a concept that kind of gets at some of these elements is a mobile app for diabetic patients that helps a care manager deliver an insulin dosage to the patient via the app along with a video chat request. And then the patient has the option to chat with that care manager. They can both see themselves face to face. They know they're looking at the same thing. And then they can both look at that dosage while they're video chatting. So they have that contextual conversation going on. And then immediately following, they have a recording of that conversation that the patient can then share with the rest of their care team. And then finally, the last design principle I'll talk about is the idea of giving control. I know ownership is kind of a tricky term when it comes to patient information, but ideally the patient should own the care plan and control who sees it. And a really simple concept for something like this is just allowing the patient to toggle on and off the different care team members, what they can see, not only the entire care plan, but specific elements of that care plan. And then maybe even setting an expiration date for how long that person gets to see that information. And that can also be relevant for giving the patient the option to donate data to research efforts as well. But the problem is that's not usually the case. The patient doesn't really own their data. Well, they do in one state, New Hampshire. But the rest, it's either legally ambiguous or the clinician or health system owns the patient's data. And it's also important here to think about when you're transitioning to control for the patient, to also think about collecting meaningful consent. That's essential to giving patients control. And some organizations are already kind of starting down this path, like Sage Bionetworks and the ONC that both have open source toolkits for e-consent tools. So these are all design principles that can be employed in care plans today. They're all being designed, and these elements can be incorporated. But I'll move a little bit towards looking to the future of what care plans can be. As we start to shift towards more organized population efforts like the PMI, we can develop systems that pull from national standards for population-informed personalized interventions. There's already some steps towards using advanced data analytics to deliver interventions by organizations like the MITRE Corporation and Beyond Health. But with a rich research-based library of care standards, we can start to leverage it along with advanced health tracking technology, eventually including genome, exome, and microbiome sequencing in more automatic interventions delivered to the patient through engaging interfaces. It's a great video. So we as humans are too distracted by our daily activities to recognize poor health patterns and identify the right solutions. To reach the best outcomes, our care plan should always be fine-tuning and changing, just like our lives, and we can't rely on our limited supply of high-level medical professionals to do it. We have to continue to utilize technology, policy, and culture to educate and empower people to take control of their future health. So to review, I've mentioned 7 design principles here, but an essential foundation to implementing each and every one of these is personalized education, delivered at the right level, in the right way, at the right time. But this is just a start. These are by no means exhaustive of all of the considerations for designing care plans, and there's many more to think about. As services develop further, I'm hoping more designers, developers, entrepreneurs, and healthcare professionals will engage in discourse about care planning to drive better outcomes. But by far, the most important of any of these principles is the first. Gone are the days of avoiding our health when we all have a dynamic, collaborative, engaging care plan in hand. Thank you so much for your time, and to everyone that helped provide feedback or gave research or feedback to the project. And with that, I'll end with my own care plan and move to any questions that you have. Yeah, that's a good question. I think one of the biggest barriers there is there's not really any kind of means for the doctor to create a plan. There's not any one standard for the doctor to kind of pull from content and to create. I think once we start to move to a point where we have standards of care for things like birth and the various other conditions that we know really well, then that makes it really easy for the doctor to work with the patient and create a plan that works for them. Does that answer your question?
Yeah, I mean, I think it's culture that.
Yeah, culture is a big part of it.
But I think
yeah, I mean, part of that is just that the patient is the one that owns the plan, right? So if they disagree with the doctor, then that's up to them to kind of take it and move to other care team members. Yeah, I mean, that's a great question. That's one I don't know the answer to. But that's a tricky line that we need to definitely put a lot of resources towards figuring out is what is that line, not only between what the doctor can and can't recommend and what the service can, but also what the artificial intelligence of the service has the ability to recommend, right? So there's a fine line there, and I recognize there's a lot of liability there, but once we start to get to a point where we can start implementing these, then we can kind of cross that bridge.